I want to move on. Let's take a look. We've been discussing money. We've been discussing society. We've been discussing all kinds of plans to improve adherence. I want to talk about some medicine, some real clinical medicine here for a minute. Take a look at some of these approved oncolytics, because we've been talking about them in abstract. Let's talk about specific ones. There's one that's ixazomib.
Ixazomib.
Did I pronounce that right?
Yeah.
Yeah.
Sure
okay.
Did.
That's for your practice, right? That's multiple myeloma.
Yes. So it's an oral proteasome inhibitor that was approved in combination with lenalidomide and dex for patients with multiple myeloma. So the precursor to that was bortezomib, or Velcade, which was the subcutaneous injection. And now a lot of people that were on an injection can be switched to an all-oral regimen. So to have a completely 3-drug all-oral regimen for patients with multiple myeloma was a novel and very exciting thing.
It's a big deal because Velcade is very labor-intensive for patients. I mean, patients would have to come in twice a week for, 2 weeks on, 1 week off, endlessly to get this drug. I mean, this is a regimen that patients can come in, some cases once a month if they're doing well.
How long do you have to treat patients
until
with
progression? So these patients, this is for the relapse setting. So once their disease relapses, they are on treatment forever until the end of their life. So this is an opportunity, and this patient, this treatment regimen, people can be on for years, months to years, and
Tell me a bit about the drug. What's the tolerance for this drug?
So it's given once a week. The side effects tend to be either GI, so you can have diarrhea, you can have rare, bowel perforation, very rare, but it can happen. Neuropathy, it's less than with Velcade, but you can have neuropathy, and rashes. You get some rare rashes around the eyes and around the whole body.
Mm-hmm. And do patients like it? I mean,
overall,
do they prefer
yes.
it?
They do. They do. Yeah.
And the cost?
I want to say, I'm not sure, but it's over $10,000 a month for 3 pills a month.
There's giggling on the panel, but this is a real disease, and what I mean by that is a real toxicity. It's life limiting.
Yeah.
Right. And this
right.
drug gives you life.
Yep.
Not just a day or an hour, but
months to years.
Months to years.
Mm-hmm.
So here, this would pass all the tests we discussed in the past. This would pass this drug works. It adds a significant extension to your life expectancy, that it's taken at home. Mm-hmm. Patients like it. It passes the smell test on all of these things. So is there a downside to this at all, other than money? She's thinking hard.
No, I mean, it's a good regimen. Yeah.
Again, the only downside would be for those practices that don't have dispensing pharmacies, that aren't making money on those drugs.
Okay, let's go to another one. There's regorafenib. Did I do all right on that one?
You did say it right, yes. So,
hot diggity. Now, this is an interesting tumor, HCC.
Right, so regorafenib is used mostly for GI malignancies, particularly in primary liver cancer and colorectal cancer.
Right.
For liver cancer, we use it in second line, and it's FDA approved after another TKI that we use commonly called sorafenib. Mm-hmm. So regorafenib is used as second line rescue salvage therapy for those patients, and was one of the few drugs that after probably like almost 10 phase 3 clinical trials showed some advantage after sorafenib. So it is a new drug that we are using commonly in our patients.
Now, is the drug curative, palliative, what is it?
Unfortunately, it's only for patients with stage 4 disease that cannot be cured, but we know that can prolong survival and is an oral agent that you can use, and it doesn't exclude you from other potential therapies that you can be exposed to.
Now, excuse my naivete, but when I look at colorectal cancer, the drug combination that comes to mind is Folfox, which is the old
you still use it.
You
still use it. So Folfox, Xelox, and then Folfiri plus minus EGFR inhibitors if you have the RAS wild type and BRAF wild type, hopefully. But then now, when you are running out of options and you're not MSI high, which is the new kid on the block for colorectal cancer, then you have regorafenib, which is an oral drug as well that you take it it's 4 pills you had to take, but once a day. And it has some side effects, but we know we can prolong survival in patients heavily pretreated with colorectal cancer.
All right. Now, what is the side effect profile of oral regorafenib compared to Folfox, for example? Because I've known patients on Folfox, and it's pretty nasty, despite the fact that the oncologist told them it's better than others.
It's better than others, for sure. Yes, but well, they're completely different. So Folfox, it gives you more neuropathy because of the oxaliplatin induced by these drugs. The platinum agents cause that neuropathy. Regorafenib is more from the GI standpoint. So because it's an oral drug, you take it by mouth. It causes a number of patients that causes diarrhea. You also have something called hand-foot syndrome, or PPE, which is very prominent in these patients. So we are very, very much on top of those side effects. And those are the ones that we may consider the partial refill for that, because we do dose escalation.
Oh, so you want to bring them back, have a look.
Right, instead of taking like the 4 pills a day, you take 3 and then you go up as the patient does well a week later. What we know for sure is that the most of the hand-foot syndromes that are really severe, they will appear within the first week or so from treatment, so you can actually fill the full dose once the patient is able to tolerate it. So.
And again, these 2 drugs, treating really significant cancers, oral agents, taken at home, don't have to go back, don't have to get the IV infusion.
No.
And is it my sense that the side effect profile, though different, is less severe than the IV side effect profile, or is that not true?
I think they're different. I think if you're able to tolerate the dose and you do the dose adjustment, you are able to have a good regimen that the patient will do well and continue with. The neuropathy, for example, is pretty disabling if you overcome the 10 cycles of oxaliplatin. So we want to make sure that the patient is able to do quality of life. To me, that's first and foremost.
And what other tumors are out there for which oral oncolytics are available?
All kinds: lung, breast, thyroid, prostate. Then you have the heme diseases, so it's all over the board now.
This is coming. This is the new age.
Yeah.
It's here. And it's been here.
It's been here.
All right.